Mhm. All right, and I'm going to let in these last couple of people and then we'll get started. Okay, so I hear that everybody can see my screen, so I'm going to get started and welcome everybody. Thank you for joining our next Diabetes Action Canada Research Network Action Session. I'm Tracy McQuire. I'm the Executive Director for Diabetes Action Canada, and I'll be moderating today's session. These sessions are all about keeping our community informed and engaged, and we'll explore how the work of our network is put into action both in research and in community-driven initiatives to support our members in translating diabetes research into meaningful, real-world impact for those with lived and loved experience. So today we'll be sharing some important updates on one of our flagship programs, the Research to Action Fellowship Program, and I'm going to pass the floor over to Lindsay to do that. Then we're going to hear from Dr. Holly Wideman, a familiar face within our network, who will share her recent work and launch of the Community 1D platform. And this is an innovative community-driven peer support initiative. And then we will close by introducing some new faces to the DAC team. And I actually realized I should have moved my slides. We have two new members coming to join the team. So we'll have an opportunity to introduce them to all of you and understand their roles and how you can reach out to them. And then to make sure that everybody has access to today's updates, we'll be sending out a follow-up email with key highlights, useful links, and a recording of the session, especially for those who could not attend, so they can keep in the loop. And then throughout the session, we're going to be keeping an eye on the chat, but we kindly ask that you hold your questions until the dedicated Q&A time. And in the meantime, if you don't mind listening on mute, that would be very helpful. So thank you for being here, and I really look forward to the great conversation. But before I pass the floor over to Lindsay, I'm going to take a moment and share a DAC success. So I want to congratulate the team on our recent publications. So this manuscript that recently got published, and I say recently because it was now available on PubMed as of today, is about the lessons that we've learned over the 8 years of planning large academic events with our patient partners. And this publication used the Diabetes Action Canada 2024 in-person workshop as a case study. It illustrates how we started in really the beginnings of a patient engagement framework from an inform to consult stage. And we were actually able to use some co-design practices and evolve over time to align with some of the more advanced patient engagement work that we are now able to do, which leads to more meaningful patient leadership and inclusive event planning. We published this paper with 3 patient partners. And again, thank you for all of the team for being part of this team, for being part of the writing team. And those were members of the workshop planning committee, and as well as our featured speaker today, Holly. So it's all very timely that this publication came out today, and that we'll be sharing the link with everybody in today's summary. So thank you all for all the support. And if you came to the workshop, I hope you enjoyed yourself. And we're so happy to see all of it culminate into this publication for our network. So now I'm going to pass it over to Lindsay, who's going to be speaking more about our Research to Action Fellowship Program.
Thank you, Tracy. And before I start on the fellowship, that paper literally would not have happened without Tracy's leadership and continued editing and work. So huge thank you to you for not just the work over the years on the workshop, but on the paper itself. You wrangled a lot of us and we got there. Thank you. So about the Research to Action Fellowship. So a quick reminder, the DAC Research to Action Fellowship is one of our flagship offerings in our patient engagement programming. It's a paid 9-month capacity building program that is only for people that have lived or loved experience of diabetes. So those with a diagnosis or those that are family members, friends, and community members of someone with diabetes. The fellows that participate in this program co-create accessible, community-driven, and co-designed tools based on published diabetes research. The program was designed to bridge the gap between publication and action in community and in the lives of day-to-day people with diabetes. The program is now in its second year. This year, we're thrilled to have 10 fellows with us and 5 partner organizations. More on that to come in a little bit. And the goal remains the same, to mobilize research through culture, storytelling, and community voice in partnership with our researchers and policy decision makers. So a quick reminder on the next slide on what the outcomes were from last year. So last year was our inaugural offering of the fellowship. After co-designing with our circles and many other patient advocates and patient partners for over a year, we ran the fellowship for the first time last year. We had perfect. Keeping you on your toes. We had 8 fellows from over 70 applications in the first year and 4 partner organizations. I see ACM is in the room today. ACM was one of the mentors with Access Alliance. They were a partner organization last year. And our 8 fellows took 26 peer-reviewed published papers, and they created 4 projects, all available for free to download on our website under the Research to Action Fellowship heading. They created advocacy flashcards for Indigenous self-advocacy in healthcare settings, comics illustrating patient interactions in healthcare, culturally relevant vignettes for South Asian and Black communities, and infographics on mental health and diabetes management. There's a couple of examples on your screen there of 2 of the flashcards. But since we launched the resource library this January, they've been downloaded over 100,000 times, presented in 4 different countries, and accessed in over 120 different countries virtually. So obviously, we wanted to maintain that momentum from last year's outputs, and that brings us to year 2 of the fellowship. So we're thrilled to be running the fellowship again. This time it's bigger than last year. We had over 120 different applications, people ranging from 18 to over 80 years old applied, all sorts of experiences, almost every single province and 2 territories were represented in the applications this year. And this year we're thrilled to have 10 fellows with us for 5 projects. You'll see on your screen a group photo. I think Marianne's actually on the call today. She's one of our fellows this year. Congratulations, Marianne. That's our group photo of our 10 fellows in Winnipeg earlier this month. One of the key offerings of the fellowship is that we convene the fellows twice in person at different diabetes conferences. And this year we kicked off the fellowship at the National Indigenous Diabetes Association conference. And we got to know each other, did some team building, but also learned a lot about Indigenous-led work in the space and how they can apply it to each of their projects. This year, there's projects on diabetes stigma, women's health and diabetes, automated insulin delivery 101, right to diagnosis advocacy toolkit. So that one was specially reserved for BIPOC fellows, as we know that folks that live with darker skin or Indigenous bodies have much higher rates of misdiagnosis. So we're thrilled to be working with an Indigenous partner organization on that project as well. And last but not least, the Cell Therapy 101 project. One thing I'll just highlight here before I go to the next slide is all 5 topics came from requests from our community. So these are the topics that we kept getting questions about, not just throughout the fellowship last year, but in all of our focus groups, both from researchers and patient partners on wanting to have more resources, more evidence-based projects, and the fellowship will hopefully help bridge those gaps over the next year. So what's next for these fellows? They're with us, like I said, for the next 9-ish months. We kicked off in Winnipeg at the NIDA conference, and the spring as well as the summer will be really focused on biweekly training sessions, capacity building sessions. We have a session tonight on knowledge mobilization, Research 101, but also really importantly, each team of 2 fellows will be leading their own co-design sessions later this July, where we engaged last year dozens of other community members to help us make key decisions on what projects the fellows will create. This fall, we'll be bringing the fellowship cohort to the Diabetes Canada Conference in Toronto and launching their projects and also collecting feedback and sharing insights in a panel. And then by the winter of 2026, we'll be publishing these community projects, not just on our resource library, but as well as our partner organizations' websites, and disseminating the outputs throughout all of next year. Sneak peek on who the partner organizations are this year. There's an example of a national, a North American, and a global partner on your screen. So we're thrilled to be working with the Alberta Diabetes Institute on our cell therapy project. We're working with Children with Diabetes, which is a leading organization based out of the States that provides evidence-based education to families of those that live with type 1. We're working with them for our automated insulin delivery project. And last but not least, working with the Australian Centre for Behavioural Research in Diabetes, the leading global group in diabetes stigma work, on our diabetes stigma project. And that one will be the funnest one to schedule calls for, but we're gonna do it. So to wrap this up, how can you help us in this work? How can you contribute and collaborate on the fellowship? First, if you've published research in any of the 5 topic areas that I mentioned earlier, please either message in the chat or reach out to us via email, or you can even respond to the summary email you'll get after the session. We would love to share your publications in the research packages that each fellow will get so that we can help disseminate your important work in this program. If you want to help us amplify a project this fall or winter, please share our posts on our LinkedIn, share the newsletters, but also if you know of an organization or someone who's really passionate in these subject areas, let us know. Every connection and every opportunity for better visibility helps not just the program, but also the fellows themselves. And last but not least, we'll be recruiting for co-design sessions in July. These are opportunities for anyone that has lived experience that matches the eligibility criteria to join us for a paid focus group format virtually to help design these projects. So either you can join us or you can recommend someone or connect someone to this opportunity that might not know about DAC, but would really benefit from participating. So thank you so much for your attention on the fellowship. I'm going to pass it back to Tracy, who will then pass it to Holly. Thanks, folks.
It had to happen once where I was talking, but I was still on mute. Okay. So thank you, Lindsay, for really outlining the Research to Action Fellowship. I was also in Winnipeg and I met all of the fellows, and it's just so inspiring to see everybody participate, and it's been absolutely amazing. So I also want to take a moment to introduce a familiar face. So we have Dr. Holly Whitteman here. If you've been with the network for a while, you would know that Holly's been an integral part of our leadership team from the beginning. She's the co-lead of our patient engagement work, as well as a member of our steering council, and has been for many, many years. I'm going to go through the official, introduction for Holly. So I know she might be a little bit shy about it, but I'm still going to do it. So Dr. Whitteman is a professor in the Department of Family and Emergency Medicine at the University of Laval and holds the Canada Research Chair in Human-Centered Digital Health. She's also a scientist in both the VITAM Research Center for Sustainable Health and the CHU de Quebec University Laval Research Center, and an affiliate investigator at the Ontario Hospital Research Institute. Her interdisciplinary research bridges health, technology, and equity, and she is internationally recognized for her work in health communication, shared decision-making, and designing digital tools that are not only evidence-based, but truly user-centered, co-created with patients and grounded in real-world context. Dr. Whitteman has led pivotal studies in gender bias in research funding, sparking national conversation and influencing funding agencies at funding policy at CIHR and beyond, and her commitment to equity and inclusion in science is evident in both her academic and public advocacy. We also really benefit from Holly's insights, and in fact, in the publication that we highlighted at the beginning of today's session, we can really speak about how Holly informs some of that writing and context. So again, thank you for all that you've done for Diabetes Action Canada, and I'm going to pass the floor over to you to start your presentation.
Thanks so much, Tracy. And hi, everyone. I'm really happy to see everyone here today, and I'm really excited to talk to you all about this project, Find Your Community 1D, or Trouver votre communauté T1, a customized virtual peer support program for people whose lives are touched by type 1 diabetes in some way. I am speaking to you today from Quebec City, which is Huron-Wendat land, and also the traditional traditional unceded territories of the Abenaki, Wabanaki, Wolastoqiyik, and Haudenosaunee peoples. And Quebec is an Algonquin word that means where the river narrows. And it's for millennia, it's been a long-standing site of trade and meetings. And I just want to express gratitude to Breakthrough T1D and CIHR for funding this work, and Diabetes Action Canada and Université Laval for supporting the work in various ways. So this is my slide that I put in a lot of my talks. I call it my sometimes I beep slide. And I know that this is a less of a problem in this group, but just for those who don't already know, I personally live with type 1 diabetes since I was 7 years old. So I've lived through a lot of the changes, and I see some other people on the call who have also lived through the decades of changes in treatment and care that have happened over the years. But nonetheless, it remains a disease that has a lot of work that comes along with it. So, and I want to also acknowledge the team involved in this project. So there are a lot of really wonderful, insightful, thoughtful people involved. And just to speak briefly about the team structure, we have a steering committee that is over 70% people with lived or loved experience of type 1 diabetes. And nod to Lindsay for the lived or loved wording, which I adore. So that's our steering committee. The steering committee meets more regularly. There is a national research team that meets at least 4 times a year. We have an international advisory committee. And then here at Université Laval, we have a number of students who are involved. And I just want to highlight that one of the things I find interesting about this project is, I've got a lead PhD student. He's up on the left there, top left there, Abdoulaye Thiaw, who holds an MD from his country in Senegal and who has a little brother with type 1 diabetes, which is what brought him to this project. And Charles Racine, who's on the top middle there, is a PhD student in clinical psychology who's been working with me for years. And partly because of this project is actually now moving into health psychology and specifically working with people with diabetes. So it's just been interesting to watch how working in diabetes has sort of trickled out among the team. So the motivation behind this project is the fact that for people who live with type 1 in some way, it is such a constant thing. So I really liked these 2 quotes in a qualitative paper. I don't think people really understand what's involved. It's pretty much on my mind the whole time. There's no day off from it. And it's a huge thing, but no one else can see it. So it's always there, and it's massive for you, but it's invisible for everybody else. So keeping that in mind, this team came together and we created this idea of Community 1D, which is a free peer support program for people in Canada whose lives are touched by type 1 in some way. And just to clarify what we mean by type 1, I'm using that as shorthand here, but we are also welcoming people with LADA, insulin requiring forms of MODY, and people with type 3C diabetes. And I'll also state just up front that I would love to do this for type 2 at some point as well. We need to roll this out in its current form and see how it goes and learn from that. But that is something that is of interest to myself and to other people on the team going forward. So how it's going to work is people click the sign up link, they fill out a survey. We ask them questions, and these questions have been gone through and gone over by our team a number of times. But we ask questions about the person, about the role type 1 plays in their life, when they might be available for online meetings, what language they speak, and a bunch of other questions like, are there other things that are important to you? Do you have a particular spiritual or religious practice that plays a big role in your life? Do you work like a 2 weeks in, 2 weeks out schedule, and that changes when you're available? Are you really involved in sports? So there are different things, age, stage of life, that sort of thing. Then we ask people to pick up to 6 things that are important to them that they want us to consider when putting them in a group. They rank them, and then we put people in groups based on their availability, the language they speak, and what matters to them. So that ranked list of 6 things. And then they hold meetings about once a month, and we'll see how it goes. So if people are finding that the group they're in isn't really working for them, then we will work with them to find a different group. So this is what that looks like. You know, choosing up to 6 things, you check them off, and then you rank them. So the idea here, and we don't actually know if this is true, but we believe that by allowing people to indicate, to choose for themselves what matters to them when being put in a group, that we'll be able to group people who have things in common and who enjoy spending time with each other. Each of the groups will be led by 1 or 2 volunteer peer facilitators. And so the peer facilitators will be offered training and support. And the training looks like first reading some introductory information that takes about 10 minutes. Then we have a scenario-based formative quiz. So we give people, imagine this happens in a meeting, which of these, you know, what would you do? And which of these answers would be, do you think is the best response to this particular situation? And then we have a Q&A webinar with our team staff and steering committee members who can be available. And all peer facilitators are also invited to join a listserv, one in English and one in French. They can join one, the other, or both to allow for a community of practice. And we'll also check in periodically with them just to see how things are going, especially as we get started. So the role of the peer facilitators is really just to start the meetings, so the technical aspect of it, to get everyone, to let everyone in and that sort of thing, and to make sure that the meetings are enjoyable for everyone. We do have a code of conduct, so sort of 12 rules for meetings, and they include our first rule is really sort of the core ethic of the program, and that is mutual respect. So, and basically, when we were going through this and the steering committee was developing these rules, we realized, really this is our only rule. It's just that there are specific ways that mutual respect can be enacted that became the other rules. But mutual respect is the core fundamental principle. And that is enacted in things like, we don't offer medical advice. So we keep in mind that, you can share something that works well for you, but that doesn't mean it's going to work well for everyone. We try to keep cameras on when possible, and this is to build trust, but also recognizing that there may be people who have low bandwidth or who are just having a bad day and they don't want to be on camera that day and that sort of thing. So we have guidelines around that, how to make sure that everyone feels reasonably safe within these groups, within these small groups of meetings. And one of the things that we put in there is that mistakes happen. So we give each other the benefit of the doubt when we occasionally mess up on rules. We just don't want people to be repeatedly violating the guidelines that we've all collectively agreed upon. So as you can imagine, given that we have research funders, this is funded as a research study. And so we're inviting everyone who participates in the program to join the research study. The research study itself, I'm going to go in more detail about this because this is a research network, but basically the main thing is filling out a survey every 6 months. Every time people fill out a survey, they have the option, they can say no, but if they choose, then they're in a draw for $250. And at the end of the survey, people can also have the option, if they like, to get a report of their responses. And so people can themselves see how their answers change over time if they like, or they can just sort of get that feedback of, here's what I answered today. So the research study itself is a community-based participatory design and action research. We have, after some discussion, the team has decided to use a realist evaluation. So to determine which aspects of the program work or don't work for whom and why. So as I mentioned, the main part of this is a quantitative aspect. So these questionnaires every 6 months, which we will analyze using longitudinal mixed effects models. Our primary outcome is diabetes distress. And we will also do qualitative work. We're going to do interviews at 2 time points with about 30 people each time, 12 months apart, some new and some repeated the second time. And we're aiming to also include some people who have withdrawn from the program. So they're not participating in meetings anymore, but they haven't withdrawn from the research study. And then we'll use triangulation to refine the program theory, which is basically program theory is like a fancy way of saying how we think it works, why we think it works. And the entire program and study is being run in both English and French, with the option of some meetings could happen in other languages. So if there are enough people who want to meet in Spanish or Arabic or Hindi, then we will support that, providing that there's a peer facilitator who speaks that language and is available at that time. So what I mean by program theory, so this is a messy draft that is currently in a manuscript that we're working on, but the idea being that we are theorizing that within a given context, so if people are able to participate in these meetings, they're willing to share that sort of thing, and they feel connected to others who really get it. You know, I don't know if this is the case for everyone with type 1, but I've heard this from a lot of people, and it certainly happened to me, where you meet other people with type 1 and there's that sort of instant connection. There's something that you understand that you know is really difficult for other people to really get. So giving that opportunity to people, we hope that it will lead to outcomes like reduced diabetes distress, a reduced sense of isolation, increased self-compassion, which is associated with better diabetes outcomes, improved quality of life and well-being, and a whole bunch of other good things. So just to give everyone who's unfamiliar with these terms a sense of what this means. So diabetes distress, these are sample items that are in the questionnaire. So one of the questions is, thinking back over the past month, please indicate the degree to which each of the following may have been a problem for you. Feeling that I've got to be perfect with my diabetes management. We have 2 extra questions that are specific to being employed with diabetes. So worrying about your ability to do your job due to your diabetes. If the person is a parent of a child with diabetes, this says your child's diabetes instead. And then there are specific diabetes distress questions for people who have either a child or a partner with diabetes. So feeling that no one notices that diabetes is hard on me, not just on my child or my teen or my partner. So the wording of the questions is specific to the role that the person has in relation to type 1. The secondary outcomes that we're going to be measuring are a caregiver stress scale. So particularly for the people who are functioning as caregivers, to what extent are you having feelings of being overwhelmed, overworked, and overburdened? We will be using one of the most commonly used scales for anxiety and depression, which asks a few questions about people's general state of mind. We have questions about needs for care that we've adapted from the Canadian Community Health Survey about basically, are people able to get the health care for diabetes that they need? Confidence in diabetes. This is a scale about essentially how confident do people feel about managing diabetes. Hypoglycemia fear. So are people afraid of going low? The World Health Organization has a 5-item well-being index that we are using, and part of the reason for this is it's short and it's validated and it's widely used. But also we want to ask some questions too about how well people are doing, because sometimes these surveys are all about tell me how much your life sucks. The ADD quality of life. So this is a diabetes specific quality of life scale, and when we were trying to choose this scale, it was Diana Shafali who was really helpful with that. She presented in one of these meetings, and so I reached out to her to ask her about her experiences using the scale. The social provision scale, which is basically about how much, it's sort of a measure of social support, self-compassion, personality items, and then some specific things that we've created for the program. So, you know, to what extent is participating in this program helping you feel less alone? A caregiver check-in about the things that caregivers are doing for their loved one with diabetes, and healthcare and access questions. So once we're up and running, the phase 2 for this program, we are going to start bringing in webinars. And we don't want to reinvent the wheel. There are already existing programs that run webinars. So Better has some really great webinars out there. So the focus within Community 1D will really be about type 1 diabetes and well-being and mental health and that sort of thing. So, and one of the rules that we've made for these webinars is that over 50% of the speakers need to personally have lived or loved experience with type 1 diabetes. So our immediate next steps are resolving a few remaining technical issues with the French website. Otherwise, we're all ready to go. And then we're going to launch recruitment and start training peer facilitators and running the first repeated measurements. So thank you so much for your time today. I'm really excited to get going with this, and I welcome questions that people might have.
Thank you so much, Holly. It's so very interesting. I'll let anybody who's got questions come forward. And while we wait, I'll ask a question because
Yeah,
I'm so curious about this platform. What is your ideal number of people that you're looking to recruit in this first phase for the program?
300,000.
300,000.
I'm not, no, I'm teasing. That's the estimate of how many people live with type 1 in Canada. No, we're sort of anticipating maybe a few hundred in the first
Okay.
phase, and we're hoping to have groups of 4 to 6. So
Mm-hmm.
it really depends. And one of the questions that we ask people when they're doing the sign up questionnaire is, would you rather wait a little bit longer to have a group that's a better match? Or would you rather be put in a group faster, even if we can't find people who all match with you based on the criteria that you've selected? So
Mm-hmm.
really it'll depend on how wide we go, but we've really been working on getting everything ready to go. Breakthrough T1D has agreed to publicize this at the walks, which are coming up. Um, I know Diabetes Action Canada is going to help us publicize
Mm-hmm.
it. We've got a bunch of T1D influencers who are willing to share. I've already established a route of communication through pharmacy influencers. One of my concerns has always been that, it's fine for the people with type 1 who are already plugged in. But there are a lot of people out there who don't even go to an endocrinologist's clinic. And so one of the routes to reach people who aren't already plugged in that we thought of was to see if we can publicize this through pharmacists, because if you have type 1, no matter what, you got to be getting insulin somewhere. So if anyone knows anyone at Diabetes Express and could connect me with an actual human being who will answer my questions, that'd be great. I do have some good contacts in the world of pharmacy, but that's the specific spot that I'd love to get access to their email list if they're willing to do that. Um, but yeah, so that's the plan. Couple
Mm-hmm.
hundred to start, and then hopefully it will grow as we go.
Amazing.
Yeah.
Any other questions that are coming from? I see a lot of the collaborators that are around, so I think there's a lot of opportunity to learn from them about how we can amplify some of these messages. But I see, Akam, your hand is up, so I'll let you go first.
Thank you very much. Actually, I agree with Holly. Since the population is more than 5,000, so some rule of World Health Organization categorization for sampling size, so more than 384 is acceptable. Now, the more the sample size, the larger the sample size, more explanatory it will be, and at the back end for regression analysis and other analysis, it will be more helpful. So my bottom line is 384, and the larger, the better. Thank you, Holly. Yeah, it's excellent. Your plan is excellent because the sample population size is more than 5,000.
Thank you so much. Yeah, I agree. And I mean, I think the thing that we want to keep in mind is that, even though there are a lot of people who live with type 1 or who have a loved one with type 1 and that sort of thing, not everyone wants to be part of a group program, right? And so that's part of the reason that we ultimately decided to go with a realist evaluation, because this kind of thing, I think, will work for some people and may not be right for everyone. So how do we figure out, like, for whom is this right? How do we build a program that is adaptable so that it can work for lots of different people in different ways? Yeah.
Mm-hmm.
Thanks for your comment.
Great, thanks. Jessica, I see your hand is up.
Hi, I'm Jessica Kitchler. I'm at the University of Windsor, and my question is more methodological. One of the things um, I struggle with a lot in the research I do is when we are recruiting through social media and online things, is not the bots, it's the fraudulent participants. So there's bots, but you can block those out. But it's individuals that are human beings that then fake it and sign up for studies and can get past the I'm not a robot things, but they don't have type 1, they don't love with someone with type 1, and they really are in it for that random draw potential. And so I was just curious what things you're putting in place for that.
Yeah, that's a great question. I think because the program is a program of small group meetings, it would be really hard to fake this, right? So the invitation to complete the survey only goes out to people who are participating in the program. I agree with you. It is a problem with I run other kinds of studies online, and when it's just one time and we're running a survey, it is a challenge, and it seems to be becoming more of a challenge.
Yeah.
But for this particular project, I'm less worried about that, just because of the way the project runs is based on these monthly meetings where people are interacting with other people. It'd be really hard to fake having type
Yeah.
1.
Yeah.
Like that's a lot of work to go through to be
Yeah.
entered into a draw for
I know.
$250.
We're seeing it more and more. So I just
Yeah.
yeah.
No, thanks.
Yeah.
That is a good, very, very good, very scary point.
Lindsay, I see your hand
I
up.
just wanted to jump in and say that, Jessica, we've seen that on at least half a dozen projects that we support as a network, and have like tried a variety of different approaches, workshopped, even run like conversations and focus groups with people, because some of the strategies out there just aren't realistic. Like when we first started seeing it, people were like, well, ask someone for their insulin prescription. I haven't seen my insulin prescription in years. Like I don't know where to get my insulin prescription. So not everything is as applicable, but I think this is good food for thought for the little AI note taker for our next action session to do something on this topic.
I'll also plug, because I have to, I'd be remiss if I didn't, that DAC has its platform, Connected Canada, which has been dormant for a little while we've worked out a bit of staffing issues. But I am really happy to say that we're very close to hiring somebody who's going to level this platform up. And with that, at least it has that opportunity to have authentic users, because if you did any sort of recruiting through that platform, they would have had to fill out a questionnaire. I mean, they could also be fake, you're right, but at least it's not necessarily an open call where anybody could just come in. It would be through a platform like that. So we are seeing a little bit less of the bots and the people who are pretending so that they could participate in clinical trials. So you'll hear about that actually at our next network action session. So, teasers for next time. Is there any other questions out there for Holly before I ask my other one? No. So Holly, I have a question about how this connects to some of the other initiatives that I know you're a part of, and I know also have people on this call. So on this call, we have members of the CanScreen T1D group as well. I know you made my reference to Breakthrough T1D, but curious about how all of this is connecting with this platform.
So yeah, great question. For those who don't know, CanScreen T1D is a project exploring the potential for population-based screening for type 1 diabetes in Canada, and I'm a member of that team. So at the start, there's no connection. However, one of the things that we have discussed, so this was a suggestion of that Sasha made, and I think it's a really good idea, is that for parents whose children are identified as being at risk for type 1 diabetes, to offer them to join Community 1D to talk with other parents who are in that situation. So that is something that we're planning down the line. We're not there yet because we don't have, because the tests haven't been done yet, but we are thinking about this, about what that experience is going to be like for those families whose children are identified as being at risk, either due to genetics when they're quite young, or later if they develop antibodies.
Mm-hmm. Great.
Yeah.
Thank you. Any other questions for Holly before we thank her today? No, well, thank you. Oh, Akam, you came in right before I was about to close it. You go right ahead.
Just 30 seconds. Holly, a great project. And because of my skills, I can offer volunteering at any point of time for methodological concerns, methodological richness or supplements, or if I can add 2 cents to your project, I'm happy to volunteer.
Thank you so much.
Thank you.
And anyone else interested in volunteering, please do reach out. We'd love to have, this is what these community action sessions are all about. So thank you again for coming today, Holly. We appreciate learning more about this project and happy to participate in its amplification. So great, and thank you again.
Thank you so much. And I really hope that everyone in the coming days will be ready to spam everyone they know with type 1 so that they are aware of this and can join if it's something that is of interest to them.
Great. Well, thank you. And this even leads to our next thing, which is our new faces and how it's all going to lead up to how we can help. So I'm just going to quickly speak about the new faces at DAC and give you an opportunity to meet two of our new staff members who are here to really help do exactly what Holly just suggested, really amplify some of the research and the outcomes that we have within the network, as well as promote such projects like what Holly just described. So I'm actually going to pass the floor over to Lindsay. Both of these individuals do report right into Lindsay, so it makes more sense for her to introduce them than me. So I'm just going to go to the next slide and let Lindsay do her thing.
Thanks, Tracy. So one of the new team members to join the DAC team is Laurie Lepin, based out of Montreal. So she's our brand new Francophone engagement coordinator. She brings both lived and labored experience in the diabetes space. She's been a diabetes advocate for over a decade and has led different initiatives such as the VPN support network that was based out of Montreal. She was a peer leader in that work, has volunteered with various charities like Breakthrough T1D, Diabetes Canada, and prior to joining the team was also a patient partner with DAC as well as with the Better Registry. And she joined our team a couple of weeks ago to support with not just our Francophone patient circle, but also recruitment and engagement of Francophone patient partners in Quebec and outside of Quebec as well. And she's providing support on a variety of different engagement projects and outputs. Laurie's full-time job is her diabetes. Her next full-time job is her occupational therapist work, and then she's with us part-time to support our Francophone engagement. Then there's also Leisha Tory. Leisha's actually here today, so Leisha, if you want to wave. Leisha's just joined our team yesterday. Thank you, Leisha, for joining us today. So she's our community and communications coordinator, a feminist advocate and powerhouse who's done lots of advocacy and period poverty work in Newfoundland and Labrador, has distributed over 30,000 free menstrual projects across coast to coast to coast in Canada, and has advocated on the Hill as well as in community. And this past year, she was a Feminist Creator Prize finalist and winner from the Canadian Women's Foundation. Leisha is going to be with us full-time and supporting on storytelling, impact narratives, and basically connecting the dots between the important work that you folks all do, how we support you, and how we can get those stories out there, not just to funders and to other researchers and community members, but also to the policy leaders that could best benefit from your outputs and your fantastic work. So thank you, Leisha, for joining us. We're so excited to have both Leisha and Laurie join the team, and extra hands on deck to continue the great work, but also improve our communication, storytelling, and impact with all of you.
Great. And thank you again, Laurie and Leisha, for coming and joining our team. And we're hopeful to start seeing some really great comms come out, because I think this is one of the main gaps that we are starting to hear a lot more about when it comes to the work that we do and the impact that we have. So great to introduce everyone, and we'll be following up with more information on each of our new staff members. So, I'm looking at the time and, sometimes these go over and sometimes they go under time. So I'm really happy that today's is going under time, and I'm going to give everybody some time back in their calendar to do all of the things they need to do. I'm going to follow up, as I mentioned at the beginning of today, with an email that really summarizes some of those key aspects of what we discussed today, including helpful links. So I'll get the links from Holly for the website. I'll get links for the publication that I talked about at the beginning, as well as some of the new staff member information that we shared today. As always, if you don't follow us already, please do with our LinkedIn and our website. And our next session will be in September. So we've already kind of given you a couple of teasers about what we will be discussing at that time, but we're going to be talking a little bit more about our Connected Canada and the relaunch of that, as well as some cell therapy work that we're doing with our team. So we're very excited to have that featured in our next session. And with that, I will let everybody go on to their day. So thank you again for joining us, and it's been a pleasure.
Bye, everyone.
Oh, no creepy goodbye.